votre attention, s'il vous plaît. Chers invités, chers collègues et amis, bienvenue à ICASA 2023. Je me réjouis aujourd'hui d'être parmi vous pour présider cette session plénière. Je suis Mohamed Chakroun, je suis professeur en maladies infectieuses à l'Université de Monastir de Tunisie et je suis le vice-président de la Société africaine anti-sida. Cette première session plénière de l'ICASA 2023 va aborder trois thématiques importantes pour les systèmes de santé et pour la riposte au VIH, à savoir le financement innovant dans le contexte de la couverture sanitaire universelle. Deuxième thématique importante, c'est l'optimisation des traitements pédiatriques pour l'infection à VIH et les traitements innovants et la prévention. Et troisième problématique, c'est les problèmes liés au continuum des soins de VIH. Comme il s'agit d'une session plénière, chaque orateur va aborder son sujet durant 15 minutes. Il n'y aura pas de session de discussion à la fin. Je vous prie de ne pas quitter la salle à la fin de la session plénière, car une autre cérémonie, master cérémonie, sera suivie pour une durée de 15 minutes pour honorer Dr. Henry Nagai, Chief of Party, GSA. À présent, je vais switcher à l'anglais et je reviendrai au français dès qu'il y aura besoin d'y revenir. I am pleased to invite the first speaker, Dr. Nertila Tavanxhi, to talk about innovative financing for HIV in the context of universal health coverage, what works. Dr. Nertila is the manager of the High Impact and South and Eastern Africa Health Financing Support at the Health Financing Department of the Global Fund against AIDS, TB, and malaria. Dr. Nertila, you have the floor for 15 minutes, please.
Good morning, everyone. So I am speaking today on behalf of the Global Fund, and I will speak for innovative financing mechanisms for HIV in the context of universal health coverage. So let me start by saying that there are discussions about these mechanisms are innovative or have been there for a long time. However, important is to say that these are additional mechanisms for financing for both health and HIV. Next slide, please. Can you go backwards? So now, why would we need additional financing for HIV and for health? Because there is consensus amongst practitioners in the area that the best, most secure and most stable source of funding for health and for HIV is general government budgets. However, in nowadays situations, we are dealing, and especially in this continent, we are dealing with a very constrained macroeconomic situation. So we have levels of debt and debt servicing that eats into government space for social spending. These are increasing and have gone in many countries into unsustainable levels. On the other hand, the economies are shrinking. We have wars and crises and increasing food prices and food insecurity. And therefore, IMF and the World Bank have projected that for many countries, the levels of government general expenditure will take until 2027 to reach the pre-COVID levels, about 110 countries. and some 41 from these countries might not reach the pre-COVID levels even by 2027. So there is not enough government space to pay for health and for HIV. So now, next slide, please. If we go to the HIV funding trends, the latest publication for UNAIDS tells us that for certain years, the funding available for HIV, based on donors and based also on domestic investments, they have stalled against the context where 2025, to reach fast-track targets, we need to have almost $30 billion available. So the funding available for HIV and domestic spending for HIV has not kept the pace needed to reach the fast-track goals. Therefore, we need to think of, as I said, established or innovative ways to bring about more money available for health and HIV. So next slide, please. Now, if we think of these additional resources, we have to bear in mind certain criteria that they must fulfill. First of all, these resources should be sustainable, so they should be able to persist for a long period of time. They should be stable, which means that they should give you a stable base. They cannot go up and down from year to year. They have to be progressive, meaning that the richer bear a bigger burden than the poor, so the rich and the poor cannot have the same share. And they need also to be administratively efficient, meaning that there will be administrative costs to manage these new funds or additional funds, but we can't have situations where the administrative costs eat into these funds available. And we have to look also at the side effects of these mechanisms, which sometimes are unattended consequences that will impact our possibility to have the funding, but also our health outcomes. Next slide, please. So, as I said, given that the resources needed are not available, when the needs is most, if countries have to achieve universal health coverage for all their populations, affordable also from the financial burden. So we need these additional resources, first of all, to raise the financing that is not there, so for additional money. Sometimes these new resources, given that they are not connected with the government, they are outside the government budgets, can be more innovative, can risk more, and can bring about innovation. In some cases, we need this funding either to increase efficiency or effectiveness. And as countries are moving away from donor funding, these new sources can also serve as a bridging financing between donor parallel funded systems and interventions into country-owned ones. So now I will speak about a few mechanisms that we are using at the Global Fund, but also other partners and some examples for country-owned mechanisms. One mechanism that Global Fund is using increasingly is blended finance. So blended finance is basically you have different donors or you have different multilateral development banks that fund specific things. So they all come together, they pool their funding to provide more comprehensive responses, more comprehensive services, more comprehensive service delivery. And this is, from one side, strategically, this is very important because it helps the country achieve its strategic goals. On the other side, it is also better for the patient because they would receive the entire array of services and not only for single diseases. So on the operational level, next slide please. On the operational level, you might have pooling and therefore not separate administrative processes or fiduciary processes or public financial management rules. And this can be also a way to help the country's public financial management systems. On the strategic and the programmatic, as I said, the resources will be pooled, they will be used more efficiently and more effectively, and in certain cases, it will ensure a very smooth transition from donor-funded programs and interventions and systems into the country-owned ones. So I will come to you next slide with the example. Next slide. With the example of Côte d'Ivoire. So as part of the grant cycle that starts early in the next year, Côte d'Ivoire decided to use Global Fund money to do a blending with a World Bank loan facility for universal health coverage in Côte d'Ivoire. So basically there are two interventions through this blending mechanism. The first one is to include the community healthcare workers that provide malaria services into the program-based financing, which is the World Bank country loan. So these community healthcare workers will be part of performance-based agreements of primary healthcare centers. And this way, we will connect the primary healthcare centers with communities. So we are expecting that we will have better access to services, better coverage. But on the other hand, given that these community healthcare workers will be paid based on performance, we consider this as a first step for formalizing them in the country. So right away, they are mostly being funded by donors. So this is the first step that they are formalized, recognized, and go into the country payment mechanisms. So this was the first intervention. The second intervention will be the enrollment of vulnerable people living with HIV into the National Health Insurance Scheme in the country. So, so far, the people living with HIV, they will still continue to take their HIV services from the program, but through enrollment in the benefits package that doesn't include HIV services for the time being, they will get financial protection for their other health conditions like hypertension, diabetes, cardiovascular disease, mental health. And so for us, again, this is a patient-based investment where the patient will get access to both HIV through the program, to other health conditions through the National Health Insurance Scheme. And then this way, the country will also help a little bit the health insurance scheme, increasing the number of enrollees and making the scheme more viable. So this will start early next year. We still have to see the results, but this is something that we have seen increasingly, especially in the context of universal health coverage. This is a type of activity that we have seen increasingly in the grants that will start next cycle, and especially in the African region. Next slide, please. Another instrument that we are using is debt swaps. So Global Fund is an intermediary between a creditor government and a debtor government. So with intermediation of the Global Fund, the creditor government agrees to forego a debt that is owned by the creditor country, but this is done on the condition that the debtor country will pay at least part of this foregone debt into a health program that is managed by Global Fund. So you will see here the case of Cameroon, where the government of Spain forgave about 24 million euros on the condition that about 40% of this amount will be invested by the Ministry of Finance into the ARV programs. So this is one of those situations. Can you move the next slide, please? One of those situations where we have win-win situations where the debtor country has available resources for health. These resources go in very well established funding gaps activities with due diligence, with outcomes. And on the other hand, can you move to the next slide, please? And on the other hand, the creditor government feels good because they support social spending in countries that are in development. So we have a pledge to secure a deal of $100 million as part for our next replenishment through debt swaps. Sorry. These are some of the transactions that have happened across the years that have raised approximately more than $200 million. And that's the pledge there for 100 million more as part of Global Fund replenishment in the next cycle. Next slide, please. Next slide. So another innovative financing instrument, and this one is not necessarily to raise more resources. This one is to increase the efficiency and effectiveness of resources, is a program that we are funding in South Africa, which is a social impact bond for adolescent girls and young women. So you will hear more about it tomorrow. There is a session about it. I just wanted to mention here a little bit the principles. So we have a social investor that forgoes part of their interest for social spending in a certain country, and this social investor puts forward either the entire or part of the funding, and then the government or the investor will pay only when positive outcomes are reached. So this way, the government will shift the risk of this investment towards a service provider or towards the social investor. It is a very complex instrument. It has, in different contexts for different interventions, will have its own logic, and it takes a little bit of time to be put in place. However, we have a very good experience in South Africa, and we think that this is a very useful instrument, especially in the framework of public-private partnerships. Next slide. So the social impact bond in South Africa will cover adolescent girls and young women in multi-layered services. So there is a medical service, there is a mental health support, there is a gender dimension support, and this is done for adolescent girls and young women that are at school. It is done in their environment and is done through innovative means, non-invasive, and also in a context of their psychological safety. So these are the types of services that are being paid for, that make part of the outcomes, and as I said, you'll hear more about it tomorrow. Again, on the innovative financing, there is a collaboration between the Gates Foundation and the Islamic Development Bank, and with the participation in certain cases with the World Bank and the Global Fund. So this program is called Lives and Livelihoods, and there is about a 2.5 billion concessional financing facility that is set up by Islamic Development Bank and Bill and Melinda Gates Foundation. The facility provides 35% of concessional grants, and the Islamic Development Bank provides 65% of loans for capital investments. So this 35% that is concessional, that is a grant, can either go towards down payment for the interest of the Islamic Development Bank, or through to soft activities, like if with the money of the Islamic Development Bank, you build an infrastructure, then with the money from the Bill and Melinda Gates Foundation, you can provide community healthcare workers, country can provide community healthcare workers and staff into these facilities. So here we have a number of activities in the pipeline, the ones that are currently going. It is one in Senegal for the malaria program, $32 million, and one in Benin for primary healthcare and community healthcare worker programs, and this is about $50 million. Next slide, please. Next. Next. And so now this is my last slide in terms of innovative sources of financing, and these are some country-owned mechanisms. We all know that in Zimbabwe we have the AIDS levy that has a 3% taxation on income to support the HIV program. So far, it has supported the ARVs, the purchase of ARVs, and it supports a small quantity of ARVs in the country. Nevertheless, it's a mechanism that have withstood the test of times, but it is not as stable because it is really very much affected by the ups and downs of the economy and currency depreciation. So this is for HIV. Then we go to Ghana, where they have a national health insurance fund that is funded through a 2.5% value-added tax and 2.5% points that are transferred from the National Social Security and Insurance Trust. So this is the second mechanism. And the third mechanism is the Botswana alcohol tax that has been increasing over the year. So this is a representative of those that we call the sin taxes, which are mechanisms that are introduced, first of all, to modify healthy behavior or to attract away individuals from unhealthy behavior like alcohol or tobacco consumption or sugary drinks and so on and so forth. And on the other hand, to create some income that can be spent on health through these increased taxations. Now, what are some of the drawbacks, especially of these last ones? And also thinking a little bit, as we said in the presentation, of what works and what doesn't work and what are our lessons learned. So in terms of taxes especially, first of all, we need the collaboration with the Ministries of Finance, because those are the ones that deal with fiscal policy in the country. And they have to make these decisions. And Ministries of Finance are usually prudent. They don't like that much the earmarking, because it doesn't give them leeway to move funds when they are needed. So this is number one. Number two, they can be regressive, like, for example, VAT tax that is paid the same based on consumption by rich and poor is regressive for the poor. They can give also unwanted effects. For example, an alcohol tax in persons that are addicted, they might decide to forego other needs, other basic needs, to continue with their addiction. So there are some drawbacks, and then there is the drawback of different diseases coming up with their different taxes, and the times of economic downturns and all the administrative costs that are related with those. So in general, and we can go to my last slide, for taxes especially, but also for the other mechanisms, first of all, as I said, we think that government general budget and expenditure is the best means. However, we could use these different mechanisms, being aware that they have to be additional. They cannot, at least at this stage, they cannot replace government funding, but they can be additional. They can bring in resources, they can bring in innovation, they can bring in increased efficiency, and they can help also with transition. And the final word, we need to have the Ministers of Finance. With all these financing mechanisms, we need to have the Ministers of Finance on board in order to be successful. Last one. Thank you.
Thank you. Thank you, Dr. Nertila. Please take seat in the podium. Please take seat here. Dr. Nertila, please. I thank you very much for this excellent presentation. I invite the two speakers also to take a seat here with us in the podium. And I call for the next speaker, Dr. Lynda, Stranix-Chibanda to talk about optimization of innovative pediatric therapeutics and prevention. Dr. Lynda Stranix is a Zimbabwean researcher and advocate for HIV prevention and treatment for pregnant women, infants, and adolescents. Dr. Lynda, the floor is yours for 15 minutes, please.
Good morning, everyone, and thank you to the conference organizers and dignitaries here present for allowing me to share my enthusiasm, my passion for preventing and treating HIV among children and their mothers. Next slide, please. So we will cover today the targets for HIV in children, some innovations that are underway in developing new medicines, commitments to robust national programs, HIV testing and treatment, and preventing vertical transmission. Next. Children are left behind in the HIV response. If you look at the blue graph, the blue chart on the graph, 63% of children living with HIV in 2022 had been identified, compared to 86% of adults in green. And that's short of the 95%, which is our target by 2030. Of course, the same is true for children who are actually receiving ART, as well as those that are achieving viral suppression. And that's not good enough. We need to reach the 95, 95, 95 targets for our children. Next. Even though children make up only 4% of all people living with HIV in the world, children accounted for 13% of AIDS-related deaths. So we need to do better for our children, using innovative approaches with the tools and the knowledge we already have, while we're also pushing to bring new technology to children so that they thrive and survive. Children, no, go back, please. I will tell you. Thank you. Children are not small adults. And infants are not children. They cannot swallow big tablets like we have for adults. They need medicines that they can swallow. They need medicines that taste good. Also, giving a fixed dose combination of different medicines in one preparation is the best way to ensure that the right dose is administered every time to the children. As children age and grow, their bodies change the way that they metabolize these medicines, and that can impact on the dosing that we need to arrange for them. For many different reasons, developing drugs for children takes quite a bit longer than it does to do the same in adults. And that means children are once again at risk of being left out of the new innovations that are beginning to be rolled out in adults. For example, long-acting preparations. And we need to do better to avoid those delays so that our children can survive and thrive. Next. And indeed, we can do that. The pediatric dolutegravir recent story is evidence that that can be done. It is possible when multiple stakeholders join forces to accelerate the pathway to improve treatment for children living with HIV. Next. Research networks worked together with the pharmaceutical company who developed the drug to establish the safety and effectiveness of this drug. Click. Next. And they shared those data with the WHO to incorporate them in the global guidelines, and that sends a signal to countries to start planning at country level to roll them out. Meantime, key donors supported innovative collaborations with generic manufacturers that lowered the cost and allowed us to bring this medicine to the clinic faster than ever before. Next. While all of that was happening, implementing partners were developing materials to support the introduction of this new product at clinic level and roll it out in multiple countries. We need this to become the standard for all new ARVs. Next slide. But having new medicines in the clinic is not going to be alone, by itself is not going to be enough to end AIDS in children by 2030. We need strong health systems and communities to deliver whatever medicines we do have to the children who need them in time, and to reduce the number of children who acquire HIV. Next. So in parallel to the incredible work that's being done to develop new medicines, an innovative global alliance gathered earlier this year in Tanzania, in Dar es Salaam, together with community representatives, UN agencies, stakeholders and partners to commit to strengthen, coordinate, and allocate resources to robust national programs to end AIDS in children by 2030. Next. The 4 pillars that are laid out by this global alliance offer new hope for children. There is commitment to remove structural barriers to universal testing and treatment for all children and support them to remain virally suppressed. Next. To improve access to treatment and care for all pregnant and breastfeeding women and support them to stay in care. Next. Working with and for men, women, and adolescent girls to ensure that mothers are protected from acquiring HIV during pregnancy and breastfeeding. Next. And addressing rights, gender equality, and the social and structural barriers that hinder access. Next. Importantly, let communities lead. The Global Alliance pledged to partner with people living with HIV and communities throughout the process. So the tools and the knowledge that we have are used to protect and support our communities. Next. A promising way to close the testing gap in children is to find the children through family-based index testing. That's inviting adults living with HIV who are already enrolled in care to test their children, either in the communities or in the health facilities. Next. Caregiver-provided testing is a feasible and accurate HIV testing strategy for children who are aged 18 months and older. So family-based health workers could distribute oral self-test kits along with the instructions for the whole family to test themselves in the community. And such an approach has been tested in a couple of countries and has been shown to work and be feasible. That could be particularly important when our health systems face disruptions. For example, during the recent COVID upheavals that we all experienced. Next. For infants, a virological test is needed, and having point-of-care testing devices in the clinic allows us to release an infant test result on the same day, instead of waiting for some weeks for the result to come back from a centralized lab. Next. The family-based approach will also link children living with HIV to care and treatment, with the index parent already in care and receiving ART, the infant result being ready on the same day. ART can be initiated in these children right away. Next. In infants born with HIV, starting ART in the first few weeks of life reduces early mortality and disease progression. Next. In fact, That's important for their immediate health, but we also know that starting ART very early may reduce the size of the viral reservoir in these infants, and that may optimize treatment outcomes later on. Click. Next. Many different studies have shown that scaling up more potent ART medicines like dolutegravir, or DTG, will improve viral load suppression rates in children living with HIV, although some countries are still to roll out this new medicine. Next. An innovative fixed-dose combination dispersible tablet of pediatric abacavir, lamivudine, DTG, which is called PALD, provides the regimen in one convenient dispersible tablet for children who are at least 4 weeks of age or 6 kilograms in weight. So they take it once a day. For younger babies, they have to take separate medicines until they reach that weight or age and are able to transition to the fixed dose combination. Next. Of course, some children will need to transition to a second-line ART if the original regimen is no longer growing children in adolescence to promote their health and well-being, treatment approaches must optimize nutrition, neurocognitive development, cardiorespiratory function, mental health, and bone health. More work is needed in all of these aspects, but to highlight bone health, we need to select ART regimens that preserve bone health, because there is concern over children with HIV not reaching peak bone mass as young adults due to either HIV itself or side effects of the ARVs that they take. And this could set them up for an increased risk of fractures later on in life. Next. Long-acting injectable ART is another exciting innovation that could prove to be a game changer, because these injections don't rely on somebody taking a tablet every day. One example is cabotegravir plus rilpivirine injections, which are given every 8 weeks in people aged 12 and over who weigh at least 35 kilograms. So studies are underway in younger age groups and pregnant women to see if we can use these medicines in those populations. There is also interest in testing other long preparations, such as new drugs called lenacapavir or islatravir. Lenacapavir is an injection that's given only twice a year. Next. Antibodies are another long-acting preparation and a study in children. Antibodies are given by injection, and they bind to the HIV envelope and neutralize the virus. They can be added to ART in children to help clear the virus, usually as a combination of products targeting different sites on the HIV envelope. Using antibodies in children born with HIV, along with ART, may be one step closer towards suppressing the virus off ART. So that's an exciting innovation to keep watching. Next. Alternative drug delivery platforms are also under study, such as skin patches and implants. These innovations deliver the ARVs directly into or under the skin for slow uptake of the ARV and are said to be minimally invasive. Next. So we've spoken about innovations for treating children already with HIV, but just as importantly, we need to prevent them from acquiring HIV by closing the treatment gap and prevention gap for pregnant and breastfeeding women. While we may celebrate that 82% of mothers were on ART in 2022, 130,000 children still acquired HIV. Next. It's very clear that we need to reinforce the current approaches to eliminate pediatric HIV, because in about 70% of these children, their mothers were not on ART at all, or had started and had dropped off treatment. In about 20% of children, their mothers acquired HIV during pregnancy and breastfeeding. Next. We all know that adherence to daily oral ART can be challenging, and this may be especially challenging in the perinatal period. So long-acting products are of special interest for both treatment and prevention in the mother, and also for infant prophylaxis during breastfeeding. Dosing with long-acting ARVs is discreet and convenient, and the dose is directly observed during administration by the health worker. Next. Apart from reinforcing the current approaches to preventing vertical transmission, we need a very strong focus on primary prevention in mothers. In high-incidence settings, like South Africa, offering long-acting injectable cabotegravir as PrEP to prevent HIV in pregnant and breastfeeding mothers could potentially reduce new child infections by as much as 24%. Next. And lastly, immune strategies are another innovation for infant prophylaxis that's being explored. The injection of antibodies that we mentioned earlier for treatment is also being studied for prevention in breastfeeding children, with several studies underway. Although I think we are all quite clear that our long-term goal is to develop a safe and effective vaccine that can prevent HIV in our children, our adolescents, and for life. And I'm happy to say that children are now being included in trials of HIV vaccines, and some progress has been made in that direction. Next. In summary, to end AIDS in children by 2030, because AIDS is not over, we need equity and justice for women and children. We need to invest in stronger health systems, in better medicines for children, and to protect mothers and their children from acquiring HIV, which was discussed by the Organization of African First Ladies Against HIV and AIDS quite recently at the high-level meeting just a few days ago. Next. AIDS is not over. We must leave no child behind. We acknowledge all the children who participated in research studies of new medicines, their families, and the communities where they live. I thank you.
Thank you so much, Dr. Lynda, for the excellent presentation. Now I invite the third speaker, Mr. Yatma. Mr. Yatma, please take a seat with us. Mr. Yatma Fall. And we will move to master ceremony. And we come back. Please take a seat, Mr. Yatma. We will move to the master ceremony, and we come back to the plenary session. and invite Mr. Aliou Sila to the podium.
Good presentation.
Bonjour tout le monde. Excusez-nous quelques moments pour cette interruption. C'est pour célébrer une grande dame africaine. La première femme africaine à occuper le poste de directrice régionale de l'OMS chez nous. Donc, sans plus tarder, j'appelle Monsieur le Président de l'ICASA, accompagné du directeur de ICASA, pour la remise. Voilà, attention. Monsieur le Président, vas-y. Merci. Okay. Beaucoup.
Thank you. Open the page. Thank you very much. I need to say that we have interrupted this thread because we need to just attend to one detail so that our person whom we are honoring is able to travel like they should. Now, Society for AIDS in Africa, like I said yesterday, was born out of a few African luminaries who thought, let's fight HIV from within the continent. And one of those luminaries is actually here. Professor Peli, can you just stand? Professor? Yes, he was one of those thinkers who said, let's start. At the same time, I would like to recognize one of our trustees that are here, Dr. Mekelem. Meskelem, yes. Yes. But also, when I became president, there was a president before me, Professor Idoko. So those people are sitting there and they are part of this movement that let's look from within and try to sort out our own issues. And one of those ladies whom we are honoring today has been extremely exemplary on the African continent. She has fought Ebola, Zika, COVID-19, Lassa fever, HIV and AIDS. And Dr. Moeti is the World Health Organization Regional Director for Africa. She is the first woman to be elected to this position and is now in her second term. Over the past 7 years, Dr. Moeti has led a very thorough transformative agenda of the WHO, how it runs. She is a medical doctor and a public health expert, and she has got more than 41 years of national and international experience. Well, from that age, from 41 years, you can calculate roughly how old she may be. Under her leadership, we have had tremendous progress that has been made on the African continent. We have kicked out polio in Africa in 2020, and this is the second disease, as you know, after the kicking out of smallpox 40 years ago. And she has invested and deliberately pioneered strong systems of surveillance and looking at health emergencies and outbreaks of diseases on the African continent. And we know that most African countries are achieving universal health coverage to expand access to services with attention to equity and to reaching the most vulnerable groups. I would like to say Dr. Moeti, as a person herself, she's very humble, but a very sharp brain, and has worked at WHO for more than 20 years. And before that, this now shows their experience She has worked for UNAIDS as team leader in the Middle East and also in Geneva, the Middle East desk, and with the United Nations Children's Fund, UNICEF. And you see, all that experience to me is very, very important. And we have tried to honor her that way. So she's a great champion for women in leadership, in global health, and launched in partnership with the UN volunteers. And I think that she really deserves, we feel that as Society for AIDS in Africa, we feel that she deserves us to recognize her. We know that she is in her last term, and we think that this is an appropriate forum to which to recognize her with a very humble award, but a recognition all the same. So Dr. Moeti, please can you come to the podium? Please. You want?
Thank you. What can I say? First, good morning to everyone. Good morning to the HIV/AIDS community. Good morning to the action groups from different organizations that are gathered here. I would really like to express my profound thanks to my Society for AIDS in Africa brothers, leaders, different generations of you, and I'm very glad that Pierre and others are here as well, the people who were in at the start of this great movement. I recall being a program manager from Botswana, attending the first conference organized by the society, and how that has evolved. I'm very humbled, thank you, by this recognition of a girl who grew up in one of the most unequal societies in the world, South Africa. That's where I originated from, who migrated to Botswana in childhood. And as I said, who's had a strong connection to this country. So I'm so pleased that this is happening in Harare, a city in which I've lived, in which my kids spent some of their childhood, and so on. I think what I would like to say is that the HIV/AIDS movement in Africa has been an example. And you have a lot to teach other areas of health and development response on the continent. So I'd like to commend you for that as well. Thank you very much for this recognition. And just to finish the story, David, I'll be leaving WHO as regional director in a year and a bit. And in less than 6 months, I'll be turning 70. So I own that age fully, and I'm quite willing to be public about it. So ladies, we no longer need to hide our age. Half a year or so, I'll be 70 years old, and I own it completely. Thank you for the recognition.
Thank you so much. After this recognition ceremony, we resume this plenary session with the last presentation on recognizing disability in the HIV continuum of care with a cross-impairment approach with Mr. Yatma Fall. Mr. Yatma Fall est président de la Société de l'Ouest africaine. Désolé. Mr. Yatma Fall est président de la Société de la Fédération ouest-africaine des personnes handicapées. Il a aussi dirigé la Fédération sénégalaise des associations des personnes handicapées pendant une dizaine d'années et il est expert formateur en droit des personnes handicapées. Monsieur Fall, vous avez la parole pour 15 minutes. Merci.
Merci beaucoup. Merci. Merci, Monsieur le Président. Nous allons parler ce matin de... Can you hear me? La prise en compte du handicap dans les stratégies de riposte.
Please, we need some support for the sound.
Voilà, je disais donc que nous allons rapidement parler de la prise en compte du handicap dans les stratégies de riposte au VIH. Mais avant d'aller plus en avant, je voudrais d'abord partager avec vous la définition qui a été donnée par la Convention internationale sur les droits des personnes handicapées sur le handicap. Par personne handicapée, on entend des personnes qui présentent des incapacités physiques, mentales, intellectuelles ou sensorielles durables dont l'interaction avec diverses barrières peut faire obstacle à leur pleine et effective participation à la société sur la base de l'égalité avec les autres. Et ici, on retient donc que le handicap est surtout défini par rapport à l'absence ou à la limitation de participation de la personne concernée. Dans la même convention, également, il est clairement fait injonction aux États, et la plupart des États d'Afrique ont déjà ratifié la convention, donc des États qui l'ont ratifiée, à reconnaître que les personnes handicapées ont le droit de jouir du meilleur état de santé possible sans discrimination fondée sur le handicap. Ils prennent donc toutes les mesures appropriées pour assurer leur accès à des services de santé qui prennent en compte les sexospécificités, y compris les services de réadaptation. Et le rapport mondial sur le handicap, produit par l'Organisation mondiale de la santé et la Banque mondiale, révèle que plus de 1 milliard de personnes, soit 15% de la population mondiale, vit avec un handicap. Et que la majorité de ces personnes handicapées vivent dans les pays à revenus faibles ou moyens, donc l'Afrique largement couverte. Et dans les populations également pauvres, on note une présence massive de personnes handicapées qui sont généralement pas bien impliquées dans la vie publique, qui ne sont pas toujours pris en compte dans le respect de leurs droits, et particulièrement dans le domaine de la santé, qui font souvent l'objet d'oubli dans les stratégies de riposte. Des études biocomportementales ont été menées dans certains pays d'Afrique, notamment le Burkina Faso, le Cap-Vert, la Guinée-Bissau, le Niger et le Sénégal. Et ces études ont montré que le taux de prévalence du VIH chez les personnes handicapées est 2 voire 3 fois supérieur aux moyennes nationales, c'est-à-dire que chez les populations, chez le reste de la population. Et même au Burkina Faso, en Guinée ou au Sénégal, les études ont révélé que les femmes handicapées ont beaucoup plus de chances de vivre avec le VIH que leur homologue masculin. Et toujours ces études ont montré que les personnes handicapées, du fait de leur état, de leurs conditions, de leur situation, du fait qu'ils n'ont pas accès à un certain nombre de services, notamment d'éducation, du fait de leur situation économique précaire, on développe plus de risques d'infection au VIH. D'abord parce qu'il y a un accès limité aux services d'éducation, d'information et de prévention du VIH. Parce que les personnes handicapées sont de diverses catégories. Les séances de prévention, souvent qui sont développées, ne prennent pas en compte ces catégories de handicap. Il y a également les comportements à risque qui conduisent à l'infection de ces personnes handicapées. Vous n'êtes pas sans savoir que dans nos grandes villes d'Afrique, nous avons toujours dans les rues des personnes handicapées qui s'adonnent à la mendicité et donc qui s'exposent à des risques. Et il y a également un accès limité au traitement, aux soins et aux services de soutien. Et cet accès limité s'explique également par la non-préparation ou la non-formation des prestataires et des personnels de santé, la non-préparation également des structures chargées d'accueillir ces populations. Et elles sont également beaucoup plus exposées aux violences sexuelles, aux violences également basées sur le genre. Et ces violences souvent découlent de certaines croyances qui sont faites sur le handicap. Quand on prend l'exemple de l'Afrique de l'Est, par exemple, où les personnes albinos font l'objet de violences extrêmement inouïes à la veille d'élections, par exemple. Et il y a également le manque de connaissances ou les connaissances limitées aussi de certains prestataires, ainsi que la stigmatisation et la discrimination dont font l'objet les personnes handicapées. Or, une riposte contre le VIH ne peut être efficace sans aborder les droits des personnes handicapées à travers une programmation inclusive. Ce qui signifie que toutes les stratégies qui sont appelées à être mises en œuvre doivent être des stratégies inclusives, c'est-à-dire qui prennent en compte aussi le handicap. Il est quand même heureux de noter que ces dernières années, la compréhension du lien entre le VIH et le handicap a augmenté, car les organisations de personnes handicapées et leurs partenaires ont largement contribué à ce changement à travers des publications, des recherches et une programmation accrue sur la vulnérabilité et les facteurs de risque des personnes handicapées face au VIH, les impacts de l'épidémie du VIH eu égard aux déficiences épisodiques ou chroniques conduisant au handicap, les actions de plaidoyer menées par les organisations de personnes handicapées, les organisations œuvrant dans le domaine du handicap pour promouvoir dans la programmation VIH au niveau international et national l'inclusion du handicap. Il est établi que les communautés marginalisées et stigmatisées, dont l'accès aux droits humains de base est limité, présentent souvent un risque plus élevé d'infection à VIH et ressentent l'impact du VIH de manière plus significative. Et les personnes handicapées font partie de ces communautés justement stigmatisées et marginalisées. Ainsi donc, les femmes et les hommes souffrant de déficiences physiques, sensorielles et en particulier intellectuelles et mentales ont souvent été ignorées dans la prévention du VIH par les services de traitement, de soins, de soutien et d'atténuation de l'impact, ainsi que par les services de promotion de la santé, des soins de santé et de protection contre les violences basées sur le genre. C'est pourquoi nous pensons que quelques actions pourraient être menées, pas trop difficiles, qui pourraient permettre de mieux prendre en compte le handicap dans nos stratégies de réponse. Il s'agit d'abord d'inclure résolument le handicap dans le continuum de soins avec une approche suivant toutes les incapacités, c'est-à-dire tous les types de handicap. Les personnes sourdes, les handicapés motrices, les personnes aveugles, les personnes albinos, etc. Rendre aussi plus accessibles les structures de prise en charge sanitaire en respectant les normes architecturales de construction. Souvent, les structures de santé ne prennent pas en compte le fait qu'il peut y avoir des patients handicapés. Adapter également les équipements et le matériel médical. Inclure des modules sur le handicap dans la formation des personnels et des prestataires de santé. C'est extrêmement important. Promouvoir la mise en place de recherche, d'études et de collecte de données de base qui intègrent le VIH, identifier des leçons apprises et mettre en œuvre des programmations inclusives et intégrant les thématiques du VIH et de la reproduction et des violences liées au genre. Pour conclure donc, tel que stipulé par la Convention relative aux droits des personnes handicapées, le handicap est un élément de la diversité humaine et l'inclusion est le meilleur moyen d'atteindre une société plus juste où chaque personne, quelle que soit sa race, sa religion, sa condition, puisse trouver sa place et vivre heureuse. Merci beaucoup.
Merci beaucoup, Monsieur Yatma Fall, pour cette présentation très intéressante. I think now we can recap this plenary session, and I would like to thank all speakers for their comprehensive presentation. As I mentioned in the beginning of this session, the session raised many important topics for health system and HIV response. First of all, we had some information about innovation financing, and Dr. Nertila shared with us the importance of innovative financing and how innovative financing can address programmatic and other gaps by fostering innovation, increasing efficiencies, and supporting transition. And Dr. Nertila shared with us some examples of innovative financing about blended finance and also social impact bonds. About optimization of innovative pediatric treatment, Dr. Lynda highlighted the need to accelerate the pathway to improve treatment for children living with HIV. Also, the need to close the HIV testing and the virologic test gap through point of care for infants and same-day results followed by early ERT initiation. Also, the need to reinforce current approaches to eliminate vertical transmission of HIV. And also, she raised immune strategy for infants as innovative intervention for prevention in children. And lastly, Dr. Yatma Fall highlighted the right of people living with HIV with disability to access to comprehensive HIV services without stigma and discrimination. I will stop there, and before closing this plenary session, I would like to thank all speakers for the excellent and wonderful presentation, and thank you all participants for your attention, and enjoy your remaining session with ICASA. Thank you so much.